Okay, welcome everyone, and we are called to order the meeting of the Rutherford County Risk Management Committee. And first order of business is to approve the minutes of the last meeting. Do we have a motion, please? All right, thank you, Mrs. Cheryl, I believe. No, Christy Kroll. Do we have a second? All right, Ms. Hickerson, did anyone have any corrections or additions? If not, all of you in favor of that, then please say aye. Any opposed? Thank you very much. Okay, Ms. Street, start with the financial reports.
Okay, we're looking at Fund 264, comparing our monthly revenue versus expenses. For the month ending in March, revenue came in at $8,849,000 compared to expenses of $4,724,000. The difference by month is $4.1 million with a calendar fiscal year difference of a negative $946,000. Continuing on to page 2 of the report, we'll look at calendar period year-to-date revenue versus expenses. For prior period year-to-date, revenue came in at $18,319,000 compared to current of $23,407,000, with expenses coming in on prior period of $16,382,000 compared to current at $16,047,000. For fiscal period year-to-date, revenue appears on prior period of $44,699,000 compared to current period of $50,906,000. Expenses in prior period were $50,271,000, with current being $49,175,000. On page 3 of the report, you'll see that the 2018 calendar year revenue versus expenses shows a difference of $7,359,000 to the positive, whereas when you review it on a fiscal year basis, you'll see that we are coming in with a difference of $1,730,000 to the positive.
Okay, do you have questions? Let's see. Before we go a bit further, let me ask a question. On the second page there, for the calendar period and for this fiscal period, our revenue has substantially improved. I mean, the expenses are in the same neighborhood.
Yes, sir.
So what's the reasoning for this revenue increase?
Well, it's reflective of the projection of our premiums for this particular calendar year. As we take the rate increases and we do our actuarial assumptions, then you'll see that as those numbers have been trued up year over year and we've made the difficult decisions on the rate increases that we've taken, you're seeing the outcome of that in terms of expenses versus what the revenue is. And we always want, in an ideal year, we'll have very small percentage difference between the two numbers.
So this is sort of us catching up for some things that we took action on early on. So
that's right. Plan changes, anything that has an effect to the premium will be reflected in the variation between the premium and the revenue and expense difference.
So are you finished with that, or you still got some more to go?
No, so I need to do Fund 266, which is our workers' comp OJI report. So in reviewing that report for the month of March, year-to-date ending, we are showing $726,115, with prior year being $558,725. Now, the reason to kind of address the same questions the mayor had brought forth on Fund 264, the reason that you see a difference between this current year-to-date and prior period is because of a couple of high-dollar claims that we've experienced within our OJI program. And for those, we have had some safety measures put in place that weren't there previously to try to control traffic and things like that, which contributed to the injuries in which these claims were incurred. So that's the reason why you're seeing a current increase over prior year for the OJI and workers' comp program.
And this is simply the OJI business. The workers' comp is not included here?
It is included. However, the number of claims that we are seeing has dropped below double digits, so we don't see a significant of an impact on those reports as we have in the past.
So most all of this is just simply the result of the OJI program?
Yes, sir, that's correct.
All right, any further questions here, please? Okay, we don't take action on that, do we?
No, sir, we don't.
Okay, so we're ready then for Mr. Dan Good to tell us about our workers' comp and OJI statistics.
Good afternoon.
Good afternoon.
I'd like to report in the month of March, we had a total of 23 injuries requiring medical attention. Of those 23, you'll see the breakdown there. That brings the total for the year-to-date to 67. Of those 67, 49 of them are classified OSHA recordable. That resulting in 19 with restricted days, 9 with lost time days, and 23 others, or excuse me, 21 other. Next page of your report, you'll see it compares this year to the 2 previous years. We are up slightly right now. Next page is the dollars compared with the incurred dollars for this year to the 2 previous years. Basically, of course, that spike is addressed to one injury that we had in the month of January, which we have discussed previously. And of course, the incurred dollars still have a chance to come down. It usually takes about a year for those incurred dollars to firm up. Of the 23 claims, the total incurred dollars for the month of March is $44,000. 17 of those claims was with the Board of Education, and total incurred dollars there were $25,900. The Highway Department had 1 in the month for $2,750. And the remaining 5 was with the County General, and the incurred dollars there, $15,400. In the last page of your report, we break down the claims within the County General to the different departments, and you'll see where they are there as far as the physical locations.
At the end of your report, Ms. Allen?
I have a question. The Strecker injured by 14, that's a really high number for 1 month. And the cost per claim isn't that much. If you look at the Board of Ed, it was only about $1,000 per claim. But that frequency just surprises me. You'd have that many in 1 month. Do you know?
The Strucker injured in the Board of Education?
Yes.
Unfortunately, that has to do with students striking and injuring teachers and staff. It's basically where about 75% of those are from. Students that either are being redirected, or students that are fighting and teachers step in between the students and get struck or injured.
Is there ever any kind of liability back on those families, to any sort of responsibility that they engage in for this?
So I would like to clarify one of the things is that the nature of the claims in which we are receiving those struck by, there are inherent risks within the duties and responsibilities that teacher accepts with that assignment. And so in terms of the nature of the claims that we have incurred, you can tell, through your own evaluation that they're not high dollar claims. So I would, my initial reaction is that it's not likely, because it is an expected behavior within a certain population. And with the combination of that and those inherent risks, I would think that we would have a weak case to make in trying to claim back against the family on it.
It just seems surprising to me that we had so many in 1 month when you don't see that. I mean, for the whole year it was 23, and you had 14 in 1 month.
So one of the things too, and Dr. Anthony can interject, but one of the things that you will find in certain populations is that, it is the time of year where the kind of the schedule within the school system changes. There's a lot more celebrations, there's a lot more testing. Just the calendar looks different than it has throughout the rest of the year. And within certain populations, those can be agitations to them, and they're very patterned. They like to adhere to certain patterns, certain schedule. So anything like that can cause a different reaction than what that student may have done done during the normal course of the scheduled school year. So I would say that that's probably some of the contribution. It's unavoidable, but it would be some of the reasons I could think of as to why you're seeing a higher number right now. And Dr. Anthony, do you have anything to add in terms? Yeah.
The only other question that I had as you're saying that, all that makes perfect sense to me, is that I'm just curious, were these injuries created, were several of these injuries created by the same student, or is this genuinely 13 different students?
Different students. We don't see a pattern. Now, if we did identify a pattern like that, then we would take additional action in that regard, but typically it's different schools, different students. Yeah. Anything else, Dan?
That's all. I wouldn't have anything.
Any further questions of Mr. Goode? All right then, sir. Thank you very much. All right, wellness update. And I have here Mr. Chuck Chapa. Is that you? You can tell me if I mispronounced that word or not. That's close enough.
Thank you, everyone. So currently, for our Know Your Numbers campaign for the health assessments, we're up to 212 as opposed to 270 for last year. Our current biometrics through both clinics and through your personal physicians are 883 as opposed to 833 as of last year. For both completions, both the biometrics and health assessments, we're at 183 for individuals that have completed both, as opposed to 383 as of last year. So we managed to complete the Q1 program. It was titled Mission Impossible. I appreciate those of you that took the time to send it out to your individuals and employees. We ran them through the ringer. It was an 8-week program designed for weight loss. Basically, it was to help to establish and improve current lifestyle choices, diet, exercise programs, things like that. A little bit of the outcomes that came from that program. So of the about 110 participants that we had a 4% reduction in total body weight of all participants. We had an average of about 8.1 pounds lost. The top male category resulted in losing 18 pounds. The top female lost 29 pounds. About an average of a 2% weight loss, loss in waist circumference, and a 200% increase in our social media activity through our Smart Steps Facebook page. A few notes from this: we had participants from across the county. We had Highway, we had Board of Education, we had Sheriff's Office, so we had a really good turnout across the board for this particular program.
Jeff, are you finding that you're getting the kind of the repeat customers, or is there new engagement occurring?
This particular program, we saw a lot more new engagement. I think a big contributor to that was being able to send it out to the Board of Ed. We saw a major uptick in participants for that year. That said, though, we do see a lot of certain repeat customers for that as well.
Good, we want to. We just want to be able to continue to pick up new faces along the way.
We really appreciate being able to get that communication pieces out to the respective departments, and it shows that when we do get it out to these individuals, they do manage to participate and we can produce results. Just a few upcoming and current events that we have. So we have the Q2 program is in full swing as of right now. It started on April 9th. This one is a step challenge. It has about 220 participants. Basically, each week they work as teams to try to have the mass amount of steps that you can get as a team. So the team with the most steps at the end of the challenge will win a selection of the prizes. Our next lifestyle management class that's coming up, that'll be on May 10th, is going to be on grilling season. It's based around, meal planning, made easy is the title of what we're going to be doing for that one. MedPoint is also going to be conducting sports physicals. They'll be doing it at Stewart's Creek location on April 28th from 7 a.m. to 11 a.m. And then the Life Services EAP webinar will be the Creating Positive Interactions. It's on demand, so they can log in at any time and be able to access that if they need it. All righty. I did want to take, in closing, just take a few minutes to talk about the spotlight for this month. So this is going to be the Cigna Health Management Program. Basically, what this is based around are certain things that Cigna may call anyone that is a member. So basically, the reason why they do it is to touch bases with you and to get you, if you may qualify for certain programs, certain things like that. So just to touch a little bit about what it does, you may get an actual individual, an online health coach, or you may get a telephonic prompt to begin with. That telephonic prompt is going to be different than actual telemarketing service. What it does is it will initially screen your call as they're talking to you and get you to the particular service that you need or that you may be eligible for. So on the back of that, certain programs that they may be reaching out for will be if you're identified or if you've shown interest on your website for certain things like stress management, weight management, tobacco cessation, the health coaching program that's available 24/7 and can be utilized. Also things like chronic condition support. So if you are identified with or you do see help for a chronic condition, they may reach out to you. They may reach out if you miss a medical appointment or you haven't refilled a prescription for a certain amount of time. Pharmacy claim or pharmacy information, so if you are in certain disability programs, and also if you're currently seeing a case manager, they will also be reaching out or could potentially be reaching out for those situations. Now, for a lot of these programs and activities, they'll reach out, but you have to answer the phone. If you don't answer the phone, certain information is HIPAA protected, and they cannot leave it on your answering machine. For certain information, it's protection of your privacy as well, in case you had a family member or multiple people in the household. So that said, if you do want them to be able to leave messages, you can contact Cigna customer service or the number on the back of your card and identify that, as well as if you would like to stop receiving these calls, you have to answer, or you can call Cigna customer service and request to not have these calls for these particular programs. But were there any questions while I'm on that?
Mr. Chapa,
Sir.
many people don't even have a house phone anymore.
Yes, sir.
So do we have cell numbers for all of these people that are in our program?
It will be for the phone numbers that you registered with your MyCigna account or for your Cigna information. So it's based off of whatever number that you have registered for health insurance.
Most of us that have cell phones are now beginning to get a few of these telemarketing calls. We don't know how they're getting our numbers, and none of us want to answer any of those calls.
Understood. I can understand
So is it
that.
possible that we could, at least on a soft landing, send some sort of communication out with our people that they're going to be receiving these kinds of calls?
Yes, sir, and we've sent these communication pieces out as well to the whole county through these communication pieces, just to make sure that they understand.
So
that these
everybody
are
has
hazard calls.
this in their hands to know this is a coming, right?
But if we could get assistance too, just kind of as we get this information, spread it around to the certain individuals. That way, it explains they are actually trying to reach me. It could be something as simple as, hey, I didn't fill my prescription last month, and they're checking to see if something's wrong.
Was it last week, Mr. Chapa, that we actually sent out the email, or the week prior? I know it's been within the last couple of weeks that it
In
went
the
out.
last 2 weeks.
And
it
I know
was.
that it was received and read. It was included in the Risky Business newsletter, because I started receiving emails from people saying, I need them to call me when I'm not at school, here's my updated phone number. So we did get some positive feedback from that.
The important factor of this as well is that you can call anytime 24/7 to the Cigna customer service line, and if there is a particular program or you just want to know, are there programs I'm interested in, or things to just be as simple as I would like to opt out of phone calls, you can call the Cigna customer service line and request that, and they will help you get to that.
Is it the same phone number that, like we could send out and say, program your phone, this will be the call from Cigna, or do they use different phone numbers every time they call?
Reason why it will be different phone numbers, simply because it'll be several different programs. Each one of these, if you talk to the case management line, that's a different department, or if you talk to the health coach line, it may be a different department. So it won't be one specific number, and for that reason, it does get a little tricky with that one.
I've had a couple of guys get phone calls while they're at work. Is there a way that, how do they pick and choose what time to call? Because, I had one of my foremen come in and he said his phone rung because he was expecting a call. And he couldn't hardly understand them or hear them because he was on a piece of equipment. So how is it, or is there a certain time that you call, or what's that?
So they usually pick it's based on what the prime time to reach certain individuals were. If you do work an alternate position like highway, that will be a factor that is tricky. What I would recommend is that he can actually request, depending on what the program is that he was talking to or whatever, you can request or identify the prime times to call you with whatever coach or whatever program you are, and they'll work to accommodate towards that. So the big thing with this is they can cater to a good majority of different things. It's just you have to pick up the phone call, you have to talk to someone and tell them what you need, be it enroll, opt out, call me at this time, things like that. But definitely have to answer the phone.
This may be too, far in the details, but it seems like somewhere, if I recall, I heard that they would typically try prime time being daytime hours initially, and after so many unsuccessful attempts, then they'll try a different window. Is that correct?
I couldn't speak to the exact technicality of that, but I can do a little bit more research and find out.
It seems like somehow I may be making that up.
I do know just from past experience, certain agencies do something similar to that. Yes, ma'am.
Clarify, this is an opt-out, not an opt-in program.
Yes, you can opt out.
That's a decision we made?
Or do
Is that a decision that we made?
It's a decision that Cigna makes through the structure of their disease management and case management programs in which we buy into.
Okay. So these people that will be calling, are they third-party vendors to Cigna?
No.
They are all Cigna employees?
Yes. It's all secured, 100% HIPAA protected, and that is why they take so many special measures to make sure that that information is protected.
Yeah, so Cigna identifies whom to contact based on claims activity, and therefore, if you'll remember back in the Zensi days, which was our initial HRA process, I'll call it process to be kind, we did a lot of promotion around the HIPAA protection and privacy, and Cigna does not share with a third party, those type of things. So the same rules apply in these type of programs as well. That's why they're all Cigna employees.
Questions? Thank you very much.
Thank you. Well, I had one follow-up question, Mr. Chapa. On these Know Your Numbers, we only had 183 people that did both HRA and biometrics. So is that basically because of the way we've changed whatever our requirements were about this process, or?
No, so the requirements are the same this year as they were last year. We did attempt to incentivize, which is what I think you're referring to, Mayor, where we would offer different, drawings we gave away iPads and things like that to motivate people to get this done sooner rather than later. We did not see enough participation increase to cost justify doing that same process again this year. So, when I look at these and knowing that school's about to get out, and that's the largest percentage, it does, it concerned me last year as well, though, whenever we were at 270. It concerns me this year that we're at 200, because a lot of people like to use our MedPoint clinics, and it is difficult whenever everyone starts going in August and September for us to manage in terms of a wait time. They do a good job at the clinic, but it causes a wait, and people don't like that. And so, that's my concern, is for them and their schedule, trying to go before work and get to work on time and things like that.
That and one commonality that takes place is people will rush to go get their biometric screening, and then they will wait until the last possible second for their health assessment. So the numbers will be very drastically different. So I would just, as from past experience, any assistance we can get to communicating, we'll continue to communicate our programs. We have several programs in place where we go into schools and throughout Rutherford County to communicate it. But it's everyone, as many people as we can, complete your health assessment, log in. We're here to help and facilitate any questions and assistance with that as well, but we can only help and assist with what we know about.
So this health risk assessment, excuse me for asking questions I'm supposed to know answers to, is this just something you do individually online?
Yes,
Yes,
sir.
sir.
You don't have to go anywhere to do that?
No,
That's
sir.
correct.
Okay, so everybody can sit in their seat if they have a computer access and do this. Okay, so they've got all kinds of flexibility about when they may want to do that.
And we have a lot of
24 hours a day.
We also have app capability. You can do it on your phone. Technically, we could all do it right here, right now, if we wanted to.
Okay, all right. All of our grandkids can do this in 5 minutes.
And they can help
Okay,
us.
thank you.
Thanks, sir.
Okay, we're going to get a report from clinic utilization at MedPoint by Shannon McNair.
If you all will recall, this is a new report that I'd mentioned, I think at the last meeting, that we'd be adding. Previously, we had our clinic experience and our standard reporting combined. When we modified the standard reporting to the new format, it excluded the clinic, so we want to be able to give you that information as well. So Ms. McNair will start each month presenting this information to you all.
Good afternoon, everyone. Thanks for having me today. Before I get into the report, I do want to just mention, to kind of piggyback onto something Mr. Chapa said, we've recently sent out to the medical plan participants a MedPoint memo. It's a little postcard that we worked with the wellness team to complete. Just a reminder of a couple things. It has the sports physicals on there that we're doing at our Stewart's Creek Clinic. And actually, do they have a copy? Yes. Christy? So you guys all have a copy sitting with you. We just recently sent this out this week, so it talks about the sports physicals at Stewart's Creek this Saturday. It talks about the biometric screenings that we perform those there, and you have until September 30th to complete the online assessment as well as the biometric screening. And then it talks about, as you all probably recall, last month we voted with the Vanderbilt at Walgreens effective May 1st. That will no longer be a benefit offered to the medical plan participants, but they are implementing the CVS Minute Clinics and the Kroger Little Clinics at no patient responsibility, and it will be processed through Cigna at 100%. So we just wanted to make sure that we sent that out. We did send out communication via email, but also wanted something that people could have in their hands and see to let them know about these things coming up. So we did get that out this week, so people should be receiving it. Some may already have, but we just recently sent that out. Okay, I'm going to move on into the report. If you will turn to the first page, you will see clinic visits.
Ms. McNair, can I stop you before you move on? Have any of the employees in here received theirs at home yet? Has this come in your mail yet? Oh, Ms. Hickerson doesn't check her mail, or somebody gets it and puts it up. Ms. Sherrill, have you seen it at home? I know Ms. Stevenson hasn't gotten her yet. I'm just curious. Some have, some haven't. Okay. Thank you. I was just wondering.
Okay, so for clinic visits for March, you will see we had 1,699 clinics there at the MedPoint clinics. A couple of things driving that down from March of 2017. We had a reduction in appointments availability. We had a medical doctor that reduced his hours with our company. So Dr. Tippins used to see patients every Thursday, 8 a.m. to 3 p.m. at our Blackman clinic. Unfortunately, for personal reasons, had to reduce those hours and no longer sees patients there. However, I'm happy to report we have offered the position and we have an acceptance for a new medical doctor, at our Blackman clinic, and she will be there every Thursday 1 to 6 once we get her trained and onboarded. We'll probably send out a communication in the Smart Steps, the Risky Business newsletter, just saying, welcome Dr. Mishra to the team, so you guys can put a face and a name together. So we're happy to report that she'll be joining us very soon. Another thing that we're seeing there, we had around 100 less biometric screenings completing in March this year compared to March last year. You heard the numbers, so we're really encouraging everyone to come in, get that done. If they're coming in for any other lab work, say they're there for blood pressure refill or thyroid medicine refill, and we need a medication, or we need to get some blood work. Oh, have you done your biometric screening? Let's go ahead and get that taken care of today. Let's knock that out for you. And to add on to the online assessment, Mr. Chapa was speaking, they can do it on the app. You do need your numbers for that. However, there is an option that you can choose unknown. Correct me if I'm wrong, Mr. Chapa. I think there's an option you can choose unknown for those lab results and get it completed. They get it in, they know it's done, and then once we get the results to you guys, you can go back in and insert those results and get a better picture of health for yourself. So, we encourage them while you're sitting there, get it done. Go onto the app if you've got it. Let's go ahead and complete that HRA assessment while you're in the office. Any questions about the clinic visits? Okay, we're going to move to the next page, which is our visit at Walgreens. Next month will be the last month that you will see me report this specific slide. Obviously, with the change effective May 1st to the CVS Minute Clinics and the Kroger Little Clinics, we won't have any more visits to report at the Walgreens clinic, but they did have 196 visits in March at the Walgreens clinics. The next slide is just a quick snapshot of our wellness visits there with our wellness coordinator and registered dietitian on site at the MedPoint clinics. The wellness coordinator for March saw 33 total visits, 32 follow-ups, and 1 initial visit. And then our registered dietitian saw 23 visits, and that's 8 follow-ups and 15 initial. So we're starting to see an increase of getting some initial visits in there with our registered dietitian. I will say our wellness coordinator is down about 7 to 10 visits compared to other months, but with spring break, she had several that were like, not this week, you know. So we did see a reduction, and we expect those to come back up this month. The next page, you're looking at your per employee per month summary. In March, just kind of a summary of everything. Office visits for us at MedPoint on-site, it was $16.99. Retail visits was $196 at the Walgreens clinics. Total cost was $175,142. And I would like to point out there, we saw a lot less flu than we saw in January and February. And unfortunately, Tamiflu, as you all know, or some of you may know, is a more expensive medication. So between that and the decrease in the physician hours, we did see a decrease in our total costs. So I do expect that to kind of recover a little bit and be a little bit higher next year. So when I'm here next month, you guys will see that. Cost per visit, $92, and that ends up being per employee per month, $29.
So, Ms. McNair, when I look at the first 3 months of the year and I look at the cost per visit, we're running about $112 per visit when I look at the 3 months combined. How does that compare, do you know, to the retail marketplace in terms of if we're at $112 through our clinics, what does it look like if someone went to a primary care physician not at MedPoint?
Yeah, so actually I just worked with Mr. Huffman at Cigna to get those numbers. So an actual visit out in just a primary care office visit out in the community with your medical plan is averaging to about $127 per visit. So we are coming up underneath there for just a basic primary care visit. Now, for specialist visits, and I'll go over this a little bit more in detail, and I'll tell you why it's important. The community cost for a specialist visit through Cigna is about an average $187 per visit, and that's going to be important in the next couple of slides when we go into our quarterly saving or our net saving summary. So if you guys want to flip to the next slide for me. This slide is just a net saving summary. It's a very quick snapshot of our saving summaries, and then the next 2 pages it's going to go in more detail. So we'll come back to that if you guys will flip to slide 7, the net savings detail. And I think, it was asked in the first meeting that I brought this to you guys, y'all wanted some more explanation on this, so that's why we're including this in this slide this month so that we can kind of go into a more granular level of the detail of the net savings. So at the top, in A, you see direct cost avoidance at $2,598,649 for year-to-date for 2017. What direct cost avoidance is, we look at our RCM fee schedule for stuff we see in the clinic. So say a patient comes in for a medication refill for blood pressure. It's coded a certain way. Out in the community, this is what it would cost if we went to a community provider. So that is looking at direct cost avoidance. By having these clinics on site, if we weren't there, this is what it would have cost the county to go out and get those services in the community. So that's the direct cost avoidance there on line A. Underneath that, you'll see the amount of provider visits we had, the referrals that we sent out. With that, you develop a 1.3% client referral rate. The average community referral rate for this area is 9.6%. So we have a reduction of 8.4% in referral rates to specialists, which means that if we can treat it effectively in the clinic, we're going to keep it in the clinic to save money for Rutherford County. Now, we are referring out. We have those relationships in the community so that if we need to send a patient out, if it's medically necessary to send them, we will send them and have them treated by a specialist. So we do have those relationships in the community, but we try to keep what we can treat effectively and medically by evidence-based medicine in the clinic, we're going to treat that in-house. Now, that's where that $187 per specialist visit is coming in where it's important. So due to that decrease in referral rate, we avoided approximately 963 specialist visits in all of 2017. When you multiply that out times the $187 average cost, that's an additional cost savings of $180,230 when you add all that. So the next line is your avoided emergency department visits. 495. Now, how we determine that is stuff, we look at what we're treating in the hospital, treating in the clinics that you would see normally go to an ER visit or an urgent care utilization area. So we do that, and then we got the numbers from Cigna on what an average emergency room visit costs, and it's $1,393, and that's how we came up with total emergency department care cost avoided, $689,535. And if I'm getting too granular, Ms. Street, please stop me. Okay. So then below that, you will see the unique patients we have per date. So that's about a little over 8,000. So per Cigna, admits per 1,000, they're seeing about 56 inpatient hospital admits per 1,000 employees. So for us, that would be an expected admits of 448.5, and then a premise health reduction rate. So by having these on-site clinics, what are we able to reduce those admits? So we're effectively treating hypertension, congestive heart failure with diuretics, or so blood pressure, diabetes. Instead of a patient going into DKA, diabetic ketoacidosis, we're treating them, we're seeing them in the clinic, we're keeping them out of the hospital. Because of that, you're seeing a reduction of $371,459 in total inpatient care costs avoided. You add all of those up into the blue there on line B. It says additional direct cost avoidance of $1,241,224. Any questions so far? I know it's a lot of information. The next section there, you'll see provider visits, just seeing a provider, so not actual visits, but they're seeing providers only, not getting blood drawn, but seeing the provider. Time saved per provider visit, so instead of having to go out in the community and waiting 2 hours to see a community provider, they come in, we get them out, and then we use the average hourly rate supplied by Ms. Street's office. That's going to give you total productivity savings from Health Center as of $196,538. Then you look at the reduced specialist visits, which take even longer than a primary care provider visit. So again, we use that average hourly wage of an employee to additional total productivity savings from avoided visits at $99,554. If you'll turn to the next page. Another thing we look at is risk factors that we're reducing and avoiding by treating and seeing the patients in the clinics. So we take the unique patients year-to-dates, the number of risk factors reduced by the treatment that we're giving in the clinic, and you get a total health improvement savings of $430,585. And then you add up C1, C2, and C3 to get indirect cost avoidance of $726,678. And then on line D, you see our total expenses for 2017. So we take our direct cost avoidance, the additional direct cost avoidance, as well as our indirect costs avoided to come to $4,566,551, and we subtract out our total expenses. So that left us with a total net savings of $1,945,178. And if you go back just a couple of slides to slide 6, I believe it was, that is just a snapshot of everything I went over, just very quick. Here's A, B, C, and how we came to those numbers.
So one of the things, Ms. McNair, I would mention back to our conversation on the PEPM summary, your cost per visit is inclusive of labs and pharmacy, whereas the number that you quoted you received from Mr. Huffman at Cigna is strictly based on just that provider visit.
Provider visit, right. So we provide a lot of generic medications. They're on site, blood pressure, diabetes, antibiotics. I mean, we've even started in the last year, 12 to 14 months, started carrying insulin different insulin products, diabetic testing supplies, all of that is inclusive in our total expenses. So when we go to slide 5, the per employee per month and the costs per visit, so when you look at going to a provider, that's just for seeing them in the office. When you leave there, you still have to go to Walgreens, CVS, Reef Sane, wherever, and get your medication, and that's completely separate from the number of $127 from Cigna for an average provider visit. So ours is inclusive of medications, lab work, so we send stuff, lab out to Quest. All of that is inclusive in that number.
Hey, Ms. McNair and Ms. Street, the total expenses, $2.6 million, right? That's what you're projecting for us in 2017. So how do we determine that? I mean, is this a PEPM arrangement, or how is this working?
We do have a budget that is set every year that is inclusive of salaries, pharmacy, Quest, medical supplies, technology, all of that. So it's a budget that's set, and we are in contract to work within that budget.
So in their bid, they provide a multi-year budget.
And it includes all these things. It's not necessarily based on how many employees we have?
Right, so we don't pay a flat PEPM to have them.
Okay. So they provided for us their projections on what it's going to take to support these many clinics in these many locations with these hours, et cetera, right? And then,
Right, that's how the bid is written and responded to.
okay. All right, so you've demonstrated here with these numbers that the cost per visit is certainly less than typically what we have for regular visits to physicians plus specialists by a substantial amount. Okay, so how long is this contract that we have with you folks?
We are on an expansion or an extension right now for a 1 year, so through 2018, through 2019, correct, Ms. Street?
So the contract was written on a 3-year initial and then 1 year right of renewal for 2 years. And so we're in the first year of right of renewal.
So we're into the 4th year of
Of the existing contract, right? And this is their second contract with the county.
And what is you're the director of operations here. Do you have any particular medical certifications or yourself?
I'm an RN.
So you're an RN?
Yes,
okay.
sir.
This is a recent promotion for Ms. McNair. You've probably seen her here before, and at that time she was the clinic manager, and Ms. Mary Asherbranner was in the role as the DCO. Ms. Asherbranner retired in December, and Ms. McNair was promoted to the position of DCO. She is a dedicated client-specific DCO, which means she only takes care of us, and she is getting some helping hands soon. With the new clinic manager that will be joining us in June.
June 11th, yep, the beginning of June.
Right, and so we have a strong clinical team and management staff over the clinics as well. So Ms. McNair works very closely with our wellness program, all of the wellness staff, and she and I talk on a regular basis as well.
Okay, questions for Ms. McNair? Oh, Ms. Stevenson, excuse me.
I just have one question on item C1 and C2, where you use the average hourly wage per employee. Do we provide that, or it seems a little high, so that was why I was wondering. So is it?
So it's inclusive of Board of Ed too, and so that may be why it seems.
I know that's not County General's average
Correct, right.
hourly.
So I work with finance to obtain that so that it's inclusive of our entire employee population.
And thank you very much. If there are no further questions, appreciate that. Okay, we have a gentleman up here sitting with us that's going to be telling us about the next 3 agenda items, it appears. Mr. Diaz, stop-loss renewal first.
Thank you. Good afternoon, everyone. So we'll start with the stop-loss premium and performance, and basically what we did is we took a snapshot of the 7 years, so dating back to 2011 through the last policy period of 2017. Total premium spent, a PEPM rate, paid claims, and paid loss ratios during that time frame. So if you look across the board, obviously the first thing you see is the first 2 years were obviously very difficult years from a claim standpoint. But since then, we've actually run below the norms, or what we typically see in the norms. For a loss ratio over that 7-year period of 78%. The loss ratio in the past 5 years has actually been below, or right around 13%. For the fees on this side, so the PEPM rate is typically what we view from a consultant standpoint on the average, and we're looking, at county governments and municipalities. The benchmark is on average about $9.24 for the same amount of coverage. So I will say that stop loss is a little bit different than what you would typically see in health insurance. They're going to come, the bad years will come. How they typically rate this, stop loss trend is around 15% annually. So depending on the block of business, obviously we've run a lot better than that in the last 5 years. But 15% is typically, that's the trend amount that we typically see in the marketplace. We're well below that in our renewal for this year, when I'll show you in here in just a minute. But $9.24 versus what we have today at $7.21, we're well below the benchmark.
So on the loss ratio, you have on here, Mr. Diaz, that for the past 5 years, it's extremely low at 13%?
Yeah.
What do you typically see in your book of business?
Typically average, if I were looking at it, average every year is around, again, is around that 78%, but in our average book of business over 5 years is closer to around 85 to 90%.
Okay, in layman's term, what does all that mean to us? Tell us about what really stop loss is all about.
So stop loss is a component that we use within the health plan for very large claimants. So each individual has a stop loss limit that's attached to their health program. So if it exceeds that, then we aren't liable as the county for that claim any longer. So what we're seeing more of today are these $1 million, $1.5 million claims, $2 million claims. In Rutherford County's case, any individual who has a claim that exceeds $750,000, that liability would be removed from Rutherford County to the insurance company, and they would take on that liability from that point forward.
So now, this loss ratio, you said typically is 70 to 80%. What does that mean? 70 to 80% of the
premium paid in. So if we're looking at
premiums paid in,
so
is it excess of that much?
it's in excess of that much, yes.
So you're saying for the last 5 years, the loss ratio was 13% greater than the premiums paid in?
No. So the premiums paid in and the claims that are paid have been about 13% of that average of the premium.
Okay.
So loss ratio is basically taking the premiums paid and the losses that are absorbed. And what we're talking about is that 100% is the premium, and the claims that we've had have been around 13%, which is incredibly low for what we typically see.
So let me try this and you tell me if this is correct, Mr. Diaz. On here, you're showing 77.9% paid loss ratio, right? And that's reflective of 2011 through 2017,
That is correct.
And you said a minute ago that your book average is between 85 to 90%,
90%
right?
over a 5-year period.
So we had, back in 2011 was our first year that we went to 750,000, and then we got nailed, because that's the way it works sometimes.
Yes, it does.
But the 5 years prior to that had showed that we could take on the risk and increase from, I think we were at 325,000 at the time, and I had made the recommendation to go to 750,000 because our premiums that we were paying in, we weren't reaping the rewards of having that corridor there. So in looking at this, what I see is that we are in the right place at $750,000. Do you agree with that?
I agree, yeah.
Okay.
And the reason I agree is that $750,000 may seem like a lot of money, but in today's climate, the amount of $1 million claims that we're seeing now are more frequent than they were 5 to 7 years ago. While we're paying, we could up this certainly, but the chances of having a claim in any given year are more likely today than they were 7 years ago.
So if you look at, as an example, 2016. We paid $483,000. We reaped the reward of $68,000 being paid out by stop loss, and we had put $483,000 out to recover $68,000 basically. And in 2017, we put out $498,000, and we recovered through stop loss claims $214,000. Had we remained at that lower threshold, we would have paid out more in terms of premium, and although we may have recovered more in claims, you can already see just at this high threshold that your premium to claims ratio, you typically don't recover that premium most often. So you want to try to make that balance occur there to where you're taking on an appropriate amount of risk.
Agreed. And the benchmarking data that we have, we're right in line. Typically, it ranges from around 500 to 750 is that range that we're in, given our size and demographics of our group in the county and board ed. Any questions on that?
Okay, so just another follow-up question here.
Yes, sir.
2017, we paid a premium of $498,000
Yes, sir.
to basically insure us for those claims that exceed $750,000.
Yes, sir.
We only had, but this $214,000 paid claims, is that?
That is correct.
That's all claims
That's
that
all
exceeded
claims that exceeded
$750,000.
$750,000. So we had a remarkably low number there, it appears to me.
Look at 13, 14, 15, we didn't have any that exceeded the 7.
Okay.
Right.
Yeah, the thing about large claimants is that they're cyclical. They're kind of like predicting the amount of hurricanes that you'll have in any given year. You could have as many as 7, or you could have 0. The chances are that you will have them, and they will come. I think.
So you're telling us then that this 750 is about the right number, because if we look at all of these years, whatever that is, 7 years, we paid $2.8 million and we paid out claims, which allowed us to pay out claims that exceeded that 750 by $2.2 million. So we're just about on right track over a 7-year average.
Yes, sir. Yes.
And what this also tells us is that we're also on track for a bad year.
Yeah.
We're ready for another
It's
one.
coming.
About
It's
our time.
inevitable.
It runs about
Statistically,
every 5 to 7 years, so we're there.
Another one is coming.
Right.
And it's inevitable. The amount, and again, it has to do with the frequency of these large claimants today versus 7 years ago, and the advancements in technology and medical treatment.
All right, all of that to tell us, I guess,
The next page.
the next page.
The next page is basically the options that we have in front of us through our current Cigna contract. If we stay with Cigna, the ISL option will remain the same at $750,000, and the premium differential there was negotiated up 5%, or around roughly 36 cents PEPM for the employee there. So the recommendation at this point, and you can see the other two levels of stop loss, $825,000 and $900,000. I wouldn't even call them significant decreases, but they are decreases from where we are today. $70,000 annually for $825,000, and roughly about $145,000 if we move to a $900,000 specific level.
So the recommendation to the committee, based on your earlier comment, would be to stay at the $750,000 individual pooling point with the 5% increase for an individual premium per employee per month of $7.57, increasing that 5% from 7.21 of current contract. Is that correct?
That is correct.
Okay, now you've been listening attentively, so what's the wishes of the committee? Option 1 is what we currently have, the $750,000, and that's going to be going up from $498 to $505. All right, Ms. Hickerson, do we have a second? Mr. Hafner, further discussion? Ms. Allen?
The last line that says laser applies, what is that?
So all reinsurance companies, and that's where we purchase stop loss from, they have the ability to laser an individual. So for example, we have a client that has Pompeii's disease, and Pompeii's disease is a $2 million a year treatment. And this individual is lasered each year at $2.3 million, meaning that that liability falls on us. That claim does not pay unless it exceeds 2.3. So that is the right by all the carriers to look at the policy to determine if they want to take on that risk any further. But that has to be outlined in the contract. And from that, we can negotiate if we can remove the laser and/or include the laser. If we think that that individual may end up doing better in that next calendar year, then we may just say, hey, we'll keep the laser because we'll bet on that, on this individual improving, or we can accept the laser and pay the reduced premium. It works in cycles, but at this point, we don't have an individual that is lasered under the contract.
So if this was our employee, as an example, everybody else would have a $750,000 stop-loss limit, but this individual would have a $2.3 million stop-loss limit. So it's just where they go in and try to control the expenses instead of spreading the premium across on an aggregate basis from a stop-loss perspective. But when we bid, we typically will put out our bid with the request with no lasers. So we get a blended rate.
Any further questions? Okay, apparently you're ready to vote then. All of you in favor of this, selecting option 1, maintaining the $750,000 individual pooling point, please say aye. Any opposed? Okay, so that's that item.
So next, we'll go through the voluntary benefits, which will be in the packet on the left-hand side. Voluntary benefits and COBRA and FSA. We will vote on these separately. So first, the table of contents on page 2, just to give you an idea of what we'll be discussing today. The bids received, obviously, the voluntary benefits that we're discussing, critical illness, accident, and cancer, and then the other 2 benefits that we discussed, COBRA and flexible spending accounts, that will be voted on separately. So if we'll turn to page 4. So as your consultant, our obligation is to go to the market to ensure that we have a good basis of companies, and we use a 4-pronged approach. Typically, 1, benefits comparison. So we want to make sure that whomever we're using, that those benefits match up to what we currently have in place today and/or are enhanced in some capacity. The second piece is the rates. Third piece is the ease in transition. So with making a move like this, obviously we want to ensure that process, they can work well with us, our payroll vendors, et cetera, so that it doesn't cause more work to the county. And then fourth is the rating system. So everyone we looked at is an A+ rated company. We want to ensure that that is the case moving forward. They pay their claims on time, basically. We had 8 carriers that we submitted the RFP to. All responded with the exception of Benefit Vision and the Standard. Colonial and Allstate were disqualified because they didn't meet the Title VI documents needing to be signed. We move on to page 5. I'm sorry. So, we also submitted on the COBRA and the FSA to WageWorks, Discovery Benefits, Cigna Benefits Connection, Employee Benefits Corporation. All responded to the bid. However, EBC was disqualified due to Title VI and TCA 49-5-413 not being signed. It's a very good question.
Actually, yeah, that is a form that we're required to receive. It has to do with the school system. It says that they will provide background checks and other safety measures like that for anyone that will be coming into the school to represent their company.
Okay, from there, we'll go ahead and skip page 6, move to page 7. So obviously, there was a vetting process that took place on the 6 or 5 carriers that were involved in the process. After reviewing it internally, Willis and the county, we decided on 2 finalists, and that's typically the approach is to narrow it down to 2, go through the interview process, and then bullets 1 and 2 kind of go over what we discussed, what we thought were important pieces of the plan. MetLife quoted critical illness, cancer, and accident. They can administer plans on a pre-tax basis, which was important to us. They also provided a $15,000 system technology implementation credit, which is typical when you're looking at these vendors. And then they also will provide credit for time served on prior plan, which was important to us as well.
So those systems and technology credits, during the interview, it was specified that those are being allowed due to the cost for data feeds to go back and forth between us and them, and any expenses we would incur through ADP for that data feed. So that's how they absorb the cost of that as part of their offering.
What does it mean that they'll provide credit for time served on the prior plan?
So if they had credit, if they were on the other plan and if they had a claim, there wouldn't be any look-back period or would be any denial period for any claims subsequently after they enrolled in this plan.
To do with the pre-ex clause
Yeah.
under the...
Okay.
So that everybody wouldn't start with day one whenever this particular vendor could take over. If they had it with the prior carrier for 2 years, then they would get 24 months of credit walking in the door to this particular product.
Okay.
And then Cigna obviously quoted critical illness and accident, not cancer. Again, administering the plans on a pre-tax basis. They would cover the cost systems of the technology and the implementation and would provide credit for time served on the prior plan. So if we go to the next page, and this is more of a pull-out, we tried to put this on legal paper so you had an opportunity to see the benefits side by side. Unless you'd like, I can go by this line by line, but primarily what we'd like to do is just, look at this and say that we vetted this out. We looked at every line of coverage. We felt like what was in place today matched what we were currently doing with, what was in place today with Unum matched what we were currently doing in the RFP process. And as well as we possibly can. There will be some benefits. For example, if I were to point out, the skin cancer and the carcinoma underneath the cancer benefit, well, more of the skin cancer. Most of these are very minimal, even if they're giving a benefit. So a $250 benefit for if you were diagnosed with skin cancer is really irrelevant in the overall scheme of things. You could see where Cigna was offering that, whereas MetLife was not. But really, in the overall scheme of the benefit coverage itself, it was very insignificant. Oh, and another thing to point out here too is the recurrence benefit. There is some language in here, some advantages, obviously disadvantages, advantages. With MetLife paying 50% of a reoccurrence and Cigna 100% after you went through 12 months of that process. So you had a disease, you're diagnosed with cancer. You had remission within 6 months, and you wouldn't be paid for that benefit again under the Cigna policy. With MetLife, you would get at least 50% of that if you were re-diagnosed or had the same diagnosis again. Yes? The
carcinoma in situ.
yeah, it's a very good question. I think when we look at invasive, melanoma, for example, where there has to be a surgery performed for that typical skin cancer, for example, and then. I'm not a doctor, but I think that's the difference between the two. If it's an invasive, meaning that they have to take you into an operating room and actually cut versus treating it, like some skin cancers can be treated with a topical versus an invasive treatment. Yeah.
That's why I'm thinking invasive would be exterior, like skin.
Yeah.
So it's
So skin cancer is actually not invasive. Whenever they look at, you can actually have like a benign or a malignant cancer, and typically it would be more the malignant that's invasive beyond just the exterior dermis.
Yeah.
Which is why a lot of times skin cancer is excluded, because it has to be an invasive type of cancer in order for the benefit to pay out.
Paid off, yeah.
I used to work in surgery for skin cancer.
Yeah, so,
That's why I was
yeah, and I'll say that typically in these policies, to Ms. Street's comments, the payment is very low on the skin cancer side. We know that the cost for that is extremely higher than, obviously $250 doesn't put a dent in what the overall cost of skin cancer is. Yes, and they're very prevalent, especially in the South.
One of the things too, and I think that he's included some additional exhibits on MetLife, is that under the Cigna proposal on the benefit limit, it pays out, and then once the elected amount is paid out, the policy is then exhausted. So as an example, you choose a $10,000 limit, you have a heart attack, it pays out $10,000, the policy is then exhausted, and that was a major difference with MetLife. MetLife will pay out up to 3 times on the benefit that is elected. And so do you want to talk a little bit about that? Because that was an advantage of MetLife that we saw.
Yeah, so we put a little bit of information back behind, the critical illness, but there's some more on the cancer, which is back on the back page. But to Ms. Street's point, that was a big differentiator to us, because once, you'd hate for anybody to have, again, cancer's one that comes back, certainly. Heart disease, that could happen, where you have multiple heart attacks and or stroke. And the benefit of that, obviously, is that if you have that second episode, your policy doesn't expire, meaning that you can keep that in place. If you have a heart attack, 2018 of April, you have a subsequent, and you max out at the 10,000, you have a subsequent heart attack in 2019, October, under the Cigna policy, you wouldn't get paid again for that heart attack. Under the MetLife policy, you would get paid again. And given the amount of reoccurrence, especially when it comes to heart disease and other things, we felt like that was an important piece of what we were trying to provide for the employees of Rutherford County. So, from a rating perspective, we try to give you as much as we possibly can. Obviously, there's different tiered rates for employee and family, but we looked at the employee specifically, and I apologize because the headers didn't roll over to the other side, but they do follow the same line. So if you wanted to kind of tear that page out, you can just put it up above there. And get a sense of who's who. But I tend to concentrate on the last two on the far right. And you can see we looked at issue age and attained age. And our intent here was to obviously beat the in-force or the incumbent rates, which we have with both Cigna and MetLife. The other piece was to provide something that we already had in place, which is the tobacco and non-tobacco. We looked at how we submitted the RFP was through issue age. Cigna initially came back with only attained age, so we had to go back to them. That's why you'll see them with an issue age and an attained age quote here. We had to go back to them and ask them to provide us with an issue age quote.
So for the purposes of the committee, it's important that you understand the difference between issue age and attained age. So on issue age, what that means is the age at which you are at the time you elect your policy will be the premium rate that you will pay forever. It won't increase as you age. Attained age does increase based on the age you are and the rates that they have set based on for that age band. So you'll see that you'll pay more the older that you get. So that's basically the difference between issue age and attained age.
Where is this business about this age? Which page are we on?
You're actually, look on the second page of the fold-out, sir. You've got it flipped up right there.
Oh, there's another page there behind
So we're really
that.
focusing on kind of the last 3 sections
yeah.
of that particular
So
document.
Are we just going to talk about cancer here first? That's just independent
That's
of
critical illness, sir,
of the
first.
accident, et cetera?
Yes, then we'll go to the accident next, but wanted to
Just
get...
looking at those 2 pages which talk about critical illness with cancer. And these last two columns that we're looking at for Cigna and MetLife.
Yes, sir.
Charges are based, $10,000 based on attained age. I see, or issued age, okay.
We're matching the issue age with Unum, which will be third over from the right, and then obviously MetLife, which would be the last one. And then just for an overall comparison, the current rates, which would be in the first column on the left.
You want me to make the recommendation? So, as Mr. Diaz indicated earlier, when we reviewed, and it was a subcommittee that met, it was myself, representation from Willis Towers Watson, and members of the risk management team that met with both Cigna representatives and MetLife representatives in finalist interviews. And after hearing the finalist presentations and reviewing the rates, the recommendation was unanimous among the subcommittee that we accept the proposal of MetLife for our critical illness with the cancer rider.
The benefits under AFLEC look to be much richer, but so is the premium. Was that the deciding factor?
Yes, I think what we were trying to do in order to keep things as consistent as possible for the employees and their members. The thing about voluntary benefits, we know this already. The loss ratios, similar back to our conversation on stop loss, the loss ratios on those VB policies are very low. So having richer benefits sometimes is not an advantage when you're talking about voluntary benefits. The last thing, when we look at VB, it's primarily, is it cost effective? We don't want employees or of the county or the school system to be saddled with paycheck poor, is a term that's used sometimes, yeah.
So, and also, if you look at the AFLAC compared to the Unum policy, we would have probably gone with the recommendation of Unum above AFLAC simply because of the fact that the benefits are in line and there is a premium difference there. Now, some of the, it says that you can do up to $30,000 for employee and $30,000 on spouse, but one of the initial comments Mr. Diaz made was about also the ability to effectively administer the program. And the way AFLAC has it set up, they do it in increments of $1,000 up to $50,000, and that's an administrative nightmare. And so you start losing some of those efficiencies and savings from premiums potentially through the uptick of cost on your administration side of it.
Okay, I got a couple of questions. Back when you were going with MetLife and Cigna, you commented that Cigna was just quoted critical illness and accident, and Met was critical illness, cancer, and accident. But Cigna has cancer benefits in their critical illness.
I apologize. Yes, there is. It's not a true cancer policy, so they didn't necessarily a full-blown cancer benefit, and we'll talk a little bit about this as we go through this process, but yes, they did match the enforced critical illness, which included a cancer benefit in it. I apologize.
Okay, and the next thing is, do we really want to one-by-one these? Are we eventually going to get at the end where we say, okay, cancer, accident, and critical illness are all going to be this one vendor, or are we going to?
No, what we're actually going to say is
time?
critical illness and accident or MetLife, and we're not going to recommend a standalone cancer rider. We had asked for a bid for a standalone cancer rider to see what the market had and what the premium pool looked like. And so when it came back and we looked at the premiums versus the benefits as compared to the embedded cancer rider on the critical illness product, which we have today, we felt like that the best option was to continue with our current coverage level, which is a critical illness policy with a cancer rider included, and not introduce a standalone cancer product. For the reason of the premiums and recognizing what our average employee makes, we want them to be good consumers. We want to offer products that are cost effective for them, and we feel like that the critical illness with the rider attached to it is the most value for our employee population based on premiums and coverage available. So if you'd like, Ms. Hickerson, to your point, what we can do is continue on and then make a vote at the very end if you'd like.
Okay, so you're not suggesting eventually having 3 different voluntary vendors?
No, yeah. No, no, we don't want to do that. But we do want to give you the ability to review each one of these products on their own.
Okay, but before we move past critical illness with cancer, you said MetLife, okay? And I'm looking at these $10,000 based on these rates over here, comparing MetLife to which one of these on Cigna do I compare it to, the issue age or
Yes,
the
sir.
attained age?
Issue age.
Issue age?
The
Okay, so
570.
we start off with Cigna lower than MetLife, and then as we get older, then we wind up with, yes, I mean, it reverses. I mean,
Yes, sir.
we continue up and then exceed MetLife from Cigna. So how do you compare those two when the rates are better at one end on one and worse on the other end?
Yes, sir. I think what we try to do is look at the demographics of the county as a whole. We
Okay.
know that our
Look at our average age
our
group.
average employee age is higher. So when we're looking at this, it balances in the fact that, MetLife becomes a better value.
Better value
as
for
you
more of our people.
More of our people than less of our people, correct.
So one of the calculations that I did during the interview process was I looked at, what if we had a 40-year-old employee who worked till age 65, and we kept the same vendor for that 25-year span? How much would an employee pay over the lifetime of their employment for Cigna versus MetLife? And for the same product, they would pay additional, under an attained age basis, additional $5,000+ in premium for Cigna versus MetLife. Now, when you look at the issue age to the other spectrum of what you're reviewing, Mayor, and you'll see that the cost for Cigna, it depends on which bracket you're in, but, if you look at the less than 24, they're a little cheaper than they are on the MetLife. One of the things that we did consider strongly in the recommendation of MetLife was the multiple benefit, which we talked about a little bit earlier. And, again, it just speaks to looking at the value versus the amount of benefit that's being offered, and what do we want for our employees in terms of offering to them. And so that's, again, why we came back to the MetLife product.
Ms. Allen?
Of all the vendors, MetLife is the only one to exclude coverage for coma and permanent paralysis. Do you know why that would be?
What I know why it is. I think they see very little value in offering a benefit for those, because less than 1%, it's actually less than 0.5% would ever be inflicted with either one of those, is statistically. So they just don't include it in their benefit offering.
So also the opportunity from a critical you have to remember, this is a critical illness with a cancer rider. So when you think of coma, you don't often think of a critical illness, which has been
Heart
the
condition.
reason that's contributed to the coma. You think of accidents and things like that. So it's just part of the underwriting process.
What you said was actually the argument I was having in my head, which was if there's low occurrence, then there's low risk, so why would you exclude it? You could argue it either way.
You could argue it either way, yeah. I think from their stance, it's, why include it from an underwriting perspective? Because with most of these large corporations, they have to put a value in it, right? So they would have to put an increase in the rate if they wanted to cover something like that, and they felt like there wasn't a need to be competitive. The chances of it happening are very slim.
Well, if you look at coma under Cigna as well, they have a 25% benefit. So even if someone went into a coma, they're just getting 25% of the benefit.
A question, on the MetLife, there's no benefit for skin cancer. It looks like that's, I hate to say it, becoming a popular thing around here, or probably across the board.
Yeah, it's certainly in the South, and I think, again, MetLife's position on this, it comes back to an affordability. If it's like saying, I know that cost is going to be, $50,000, $100,000, whatever the case may be. You look at the benefits that Cigna's providing for it, $250. That's it. It's to them, if they include it, then they have to underwrite it, and then they have to charge an additional premium for it. I think in their minds, rather than put out a small amount, I think their intent was to provide a costly benefit for something.
You can also see we have 4 vendors that basically bid on it, and half do and half don't, so
Yeah.
it's,
Okay, so now, tell us, we've talked about this critical illness with cancer. Now, we're going to continue with these others that we'll be grouping together at some point?
Or, yes, if you'd like, we can do that, and we'll vote on the voluntary benefits as a whole, and then we will vote on the FSA and COBRA as a whole.
Since we're really not considering cancer as an option, we'll go through the accident policy, which is fairly standard across the board. So, and again, as we mentioned in the beginning, there were 8 that we looked at, 5 that ended up participating, and we also listed Aflac in here on the presentation. But ultimately, the benefits are inherently very, very close overall to what we're currently doing and between the vendors that participated in the RFP. I can go through each one of these line by line, but ultimately, if we go back to the pricing page, from a cost perspective, with the rider that's on here with MetLife, the sickness hospital confinement rider, they're coming in lower than where we are currently, and our recommendation would be to keep these, to your point, keep these 2 products together with an A-rated carrier with similar benefits and a lower cost.
So you can go ahead and walk through the accident, and then we can take questions on whatever's remaining if you'd like.
So you want to go line by line?
No, I don't. Would you all like for him to cover it line by line on the accident piece of it? No? Okay.
There.
All right.
I'd like one question.
Yes, sir.
Cigna, all this stuff up here where you're talking about line, $200, 365 days, and when we jump over to MetLife, it's same $200, but 31 days. So what does that make, what's that telling us there?
That's per cover per person,
Per
and that's
person.
hospital confinement. So that's confinement in the hospital itself.
In any one hospital stay, so.
Yes, sir.
But 365 is the total for the number of times you might have appeared there for an
Yes, sir.
accident. Okay.
Yeah.
We don't compare 31 to 365 necessarily.
No, sir, we don't. And they typically, because the language has already been set in most of these, and they try to get a competitive edge and show themselves a little bit differently than the others, they're really they're the same benefit ultimately.
So you're telling us there's really not much differential in their offerings here?
No, sir, not overall. I think they're,
The rates are just a tiny bit less for MetLife.
from Cigna, yes, sir. But ultimately from Unum, if we're looking at Unum as the incumbent, they're both significantly less than Unum.
Almost identical when you look at the variations in the 4 groupings there.
Yes, sir.
Do you need more explanation on this accident business?
Per therapy, so.
So that is unlimited then?
No, I think there's a limit to the amount of physical therapy. I can get that for you if you'd like it.
Then clarify for me, if you don't mind, when exactly does this policy kick in? Is it a supplemental policy to help offset your out-of-pocket expenses, or is it after your policy has been
There's no
exhausted? or-
offset. It's a strictly an indemnity plan. So you have a service done, you submit a claim, you get reimbursed with a check. So think of it as Aflac, and yeah, same difference.
So on the one where you said on the hospital confinement, the 365 days versus the 31 days, you're saying from an actuarial standpoint, the likelihood that somebody's going to be in the hospital 365 days is so low
Yeah.
that looks like an inflated benefit that's really not there.
It's really the same. I mean, they're saying 31 days. The chances of anyone being hospitalized in any year more than 31 days, it's very, very slim. And you can put 365 there. You could have put 364. Would have been the same. Yeah.
So recognizing that the recommendation to the committee is not going to be to introduce a standalone cancer-only plan, because when you review that plan and what the actual coverages are compared to what the premium rate is, there was more value, as I indicated earlier, in having the critical illness with the cancer rider. The recommendation to the committee for the voluntary benefits is to accept MetLife for both the accident and the critical illness with cancer rider attached.
So we need to take some action on these two products.
Vote on them separately.
I would vote on them together.
There's no more discussion. I'll make a motion that we approve the committee's recommendation.
The critical illness with cancer and the accident to be given over to MetLife. Is that right?
That is correct, sir.
We have a second. Ms. Hickerson. Further discussion? Mr. McAdoo, you're not as confused as I am, are you?
I was just thinking the right side of the room's been very quiet today.
All right. Ooh. Any other discussion? All right, then, we're ready to vote. All of you in favor of...
When is it effective? I'm sorry. This will be effective 1/1/2019.
1/1?
Yep, 1/1/2019.
Okay, all right. All of you in favor of this, then, please say aye. Aye. Any opposed? All right.
Just for the purposes of it clarifying the vote that just took place, so Ms. Allen can document it, it was for MetLife for critical illness with the cancer rider and the accident policy. We will not be introducing a cancer-only product, and the products will have an effective date of January 1st, 2019.
Was that your motion, Ms. Allen?
That worked out well, then.
Okay.
The next presentation will be on COBRA and FSA. For those that know, the COBRA is the Continuation of Health Coverage Act that allows an individual no longer employed to continue their service for their rights underneath the plan for 18 months up to 36 months, depending on their if they were disabled. FSA is a flexible spending account that you can put back pre-tax dollars and use for medical expenses. So with that, we in the beginning of the summary, we had 5 vendors that we sought out. Again, same criteria that we went through. We ended up with 2 as the finalists, and that was Benefits Connection and Cigna. And so if you'll turn to the next page, which will be, apologize, is it 13? Okay, 13. Again, our intent here was to match the current plans as closely as possible, with the process being benefits, rates, transition, and then obviously A-rated companies. As you look through this process, WageWorks was the incumbent. They provided us with a renewal. Then we had Discovery Benefits provide a quote, Benefits Connection, and then Cigna. From the review within the team and looking at this, we felt like the most cost-effective. I mean, you can look at these numbers. They're basically doing the same administrative services. Cigna is clearly the recommendation from our standpoint.
And unlike on the critical illness and other voluntary benefits that we talked about, there's not a dependency to utilize the same vendor, so these would need to be voted on separately. we can actually split out COBRA and FSA, and administratively, it's fine, and it's not confusing to the employee, because it's not always a forward-facing product. COBRA definitely isn't. It's something that we actually initiate in terms of sending the packet for election out to the employee, so they never really see that unless they become eligible.
So we're on the COBRA business here. That means these people that leave our employment may choose to continue to use our health insurance plan.
Yeah.
And this is the administrative
Cost
we have to pay these folks to do that for us.
to administer it for us, yeah. You don't want to administer COBRA on your own.
And so they accept all the liability for making sure, because it is governed pretty strictly by the federal government in terms of notices and things like that. So they will actually manage sending out all the required notices, payment coupons, collecting the premiums, returning that back to the county, all the administrative functions around it.
The maximum penalty is $1,000 a day for not sending out a COBRA packet timely. So it can be very costly.
I wanted to clarify, on the Cigna line for the annual administration fees, is that right, $351? That's not $351 per employee per month, it's a flat $351?
One per case.
Per case.
That's why you see such a difference in the cost. So the others will actually charge you more of a PEPM cost basis, whereas Cigna charges you a case basis. So if, right now we have like 11 people on COBRA, so we would only be paying for 11 people versus paying a PEPM for 6,000. That's why it's so much cheaper.
Okay.
So if we come to the bottom three lines on page 13, I mean, unless I'm missing something, Cigna's, well, the first year, it's a third of what the next lowest benefits connection is.
Yes, sir.
So is there any reason in the world not to select Cigna? So that's your recommendation from your review committee?
That's our recommendation.
What's the length of these contracts? What's the length of the contracts?
It's always 3 years
3
with
years.
1 year right of renewals for up to 2.
So is this a new business model for Cigna to bid it this way? Because I can't imagine 3 years ago, we would have chosen a different model if that had been offered to us 3 years ago. So is this a new way for them to offer this?
I don't recall that they bid
I
the
don't-
last time that we had actually sit out the bid proposal. And Mr. Huffman's here, and he may know, is this a new product offering, or you may know as well as Mr. Diaz?
As you know, I don't know if we shared, it's through our company that we own through Allegiance, and we did not start marketing their COBRA administration until probably about 2 or 3 years ago.
Yeah.
So at the last at bid time, they wouldn't have had
Had the
bid
ability
submitted.
to do it.
A drastic difference from everybody else. That's just why I was asking if it was a new way of doing things. So.
We put the pressure on Paul, too, to make sure that he got it low as he could.
Okay, do we have a motion on the COBRA administration? All right, motion and a second, further discussion? All of you in favor of that, then please say aye. Aye. Any opposed? Thank you. Flexible spending accounts.
Yes, sir, same process. Ultimately looked at 5 vendors. We've noted everyone here, WageWorks is the incumbent. Same process, wanted to make sure and ensure that the benefits and how the administration of the plan would work, and vetted them to make sure they were an A-rated company. And ultimately, in reviewing the cost of this program, the recommendation is to move forward with Benefits Connection.
Who is the recommended provider?
Benefits Connection.
Benefits Connection. Are they doing this currently?
Yes, sir.
For the state of Tennessee as well.
And for the state of Tennessee?
Yeah.
Okay. And they are the least expensive, it appears.
Franklin as well. is
They
that
are
correct?
local. They're a local business here in the mid-state as well. Been in business for a number of years now.
Okay, the recommendation is Benefits Connection. What's the wishes of the committee?
I have a question first, I'm sorry. Okay, so if there are 1,268 unique participants currently enrolled, and that's what this is calculated on, That's $42 a person to administer this each month. Why is that so expensive?
That's the market rate, and I think that's are you saying an annual, from an annual basis?
I was
or
just
is
looking at
that
the
paid?
footnote at the bottom on the assumptions, and it said fees are estimated based on 1,268 unique participants. And then I'm looking at the annual premium of the cheapest one, and that was $42. It just seems awfully high that it's going to cost somebody $42 a month to manage an FSA account. And all the bids are, of course, in line, exactly what you're saying.
Yeah.
I just don't understand why it's so expensive.
They also take the fiduciary responsibility around the FSA program, so some of that is to transfer liability,
Yeah.
which is why the costs are what they are. Yeah.
And is this about the same rate we've been currently paying?
Yes, sir. As a matter of fact, it's a little bit less than what we're
A
currently
little bit
paying
less
today.
than currently?
So it's an advantage over where we are, and it's a 3-year rate guarantee at that.
Have a motion on selecting benefits connection. Was that you? That was Mr. Bowles. Okay, excuse me. And a second by Mr. Marlin. Now, further discussion, Ms. Hickerson.
Real quick question, looking at the estimated annual year 1, 2, 3 for benefits connection, 48,670 on year 1, should that be 47,170 because it's 3-year guaranteed, or am I looking at that wrong?
It's got a $1,500 startup fee. That startup fee is included in that number. I apologize. Probably should have outlined that in the beginning.
Any other questions or discussion? All of you then in favor of selecting benefits connection for flexible spending accounts, please say aye. Aye. Any opposed? All right, thank you. Page 15, is that just a summary?
That's
of what
just a
we
summary of
discussed?
what we're going to save, Mr. Mayor. So by separating those two out and moving away from WageWorks, we expect to save roughly
47,000.
$45,000. Is it $45,000 a year? Yes, sir.
Okay. All right, if there's no further discussion of that, then we are down to number 9, the Airport Authority and Community Care discussion there. Mrs. Street.
So the Airport Authority has their first retiree who is now eligible to take insurance with them. And through that discussion with Mr. Black, he and I started looking at the process and looking at the agreements between both the Airport Authority, and then I took that evaluation to continue on to community care as well. And as you all know, we provide benefits to community care and the Airport Authority, although they are not employees of Rutherford County. It is through our agreements with them that their employees have access to our insurance program. And that's basically what it says in the agreement. So what does that mean? Well, that was a good question whenever we started looking at our retiree that we have upcoming. And what I'm coming to the committee today for, I've been working with Mr. McCreary over at the law firm and Mr. Black to actually develop a resolution that will outline basically what we're already doing today. There will be no changes in what we are providing to them in terms of the benefits. It just trues up the definition of insurance in the existing contracts that we have with both Community Care and Airport Authority. And it will include stipulations such as which lines of insurance coverage they will have access to, and it also firms up language that they will pay the total rate and have the same contribution guidelines as what the remainder of the county has with their employees. So that speaks to the 82% and the 90% and all those other numbers based on tier. And my hope was that that resolution would be finished today, but there's a lot of people that have to look at it in order to have it move forward. So we can do one of two things. I am concerned about the time of year because of the number of committees that I have to go through. My preferred recommendation to the committee would be for you to accept the understanding that this is the process that's occurring and to give me approval to go ahead and go direct to the Budget and Finance Committee with the resolution once it's completed by the county attorneys. Or the other option is I can bring it back to you so you can read it verbatim and look at the legal language that will be included in that resolution before it moves on through the various committees. So that's basically what number 9 includes. It's just a firm up language around the contract that we have in place for current services that are being provided.
Okay, I mean, that's a simple explanation. I mean, if you read our lease with Community Care, I mean, it's just doesn't say anything that clarifies or makes clear what they really have. It just says for $1 a year, and if they participate in our insurance program, we'll let them lease that property out there. That's what it boils down to. So I don't know what the airport authority lease says. I haven't read it, but we need just to sort of clean up where we are so that when something were to happen illegally or otherwise, that we would at least have a bit more definite set of definitions on what this is all about. It's just, I don't know about the airport, but it's just a broad-based sweep of the brush. So we need a little bit more, hang some more meat on this skeleton. So Ms. Hickerson?
With that being said, I have no problem with, especially since we have Mr. Josh looking into it and everybody else's eyes on it, have any problem with allowing Ms. Street to go ahead and take it to budget. Because, I mean, we're doing it now. Basically, we're just putting it down on a piece of paper, so I don't have a problem with that. So if that needs to be a motion, I'll go ahead and make that. But then I have a question just for everybody to know. We're not talking about a whole lot of folks on this plan. Do you have a rough guesstimate of how many?
I have 11 people at the Airport Authority and roughly about 150 out at Community Care that participate.
Okay, we don't have a second yet.
I'll second it, but also I got a question.
Yes, sir.
How is the 911 center, those few employees, different? Don't they participate the same way, or is it different?
They do participate the same way. However, they participate under, well, I'm going to answer it like this. I've never seen that agreement. It's my understanding they participate as an employee, but it may be something else that we need to vet out and see what the language needs to look like.
So we might want to tidy that up too at the same time?
Brought
So
up a
maybe
good
we
point, and I'll go
should
back and research it.
Include them in it too,
No, Mr. Mayor,
if necessary.
I don't know. I mean,
I'll look into it.
they're not a department. I mean, they're an entity all to themselves. So let's just, Ms. Hickerson, if you could just say, name all 3 of those as our legal, our attorney determines should they participate in a similar way. And Mr. Hafner, is that okay?
Yes.
Including the 911 emergency organization.
Are they responsible for their own OPEB? Like,
For their
you
own
know,
what?
are they, each of those entities responsible for the complete OPEB, not the county doesn't have any liability with that?
No liability there.
Yes, they are included in ours, and they would have to be because they're part of the plan. And Ms. Nolan and I love to have this conversation because you have like the financial side, and then you have like the insurance side, right? The plan is the plan is the plan. Doesn't matter how many funds are contributing to it, the plan is the plan. And your OPEB is your plan. So that, your OPEB is your other post-employment benefits. That's your liability for your retirees. Therefore, anyone who participates on your plan is part of your OPEB.
But what I was
Those
saying,
liability-
they're going to fund their portion of liability is what I was
They'll fund it,
asking.
yes,
Okay.
but we will have
Those-
to report it on the new GASB 75 reporting piece of it. We will still be including them as part of ours, but yes, they will fund it. And that's really part of, one of the reasons why when I looked at that, I thought we need to make sure our plan stays compliant, that we have that written agreement that they are going to contribute identical to what our employers. Willis Towers Watson went back and did some legal research to make sure my thought process was correct, that the plan is the plan, and they have to contribute just like we do. So, to your point, if ever so many retired that they couldn't match their OPEB, then they would need to revisit participation in our plan.
They are putting those OPEB liabilities on their balance sheet individually. I have seen those, so. Okay, we have a motion to let Ms. Street continue this discussion with the county attorney and craft the proper resolution and take it to budget. We have a motion, a second. Any further discussion? All of you in favor of that, then please say aye. Aye. All right. Any opposed? Thank you. One never gets everything tidied up that we think was already tidy before we got here. But anyway, we'll keep working on it. All right, any other business? If not, we are adjourned, and thank you very much.